And I'm gonna yeah, that's live. Okay, should all be going live here pretty soon. Well, if you are joining us, unlike Arizona, which has perfect weather all the time, well, if you are joining us, Dr. Allison Rodgers is stuck in like a snowstorm there, and so it's going to be a minute. So we're just giving her a chance to make it to the show here. So we'll give it just a second. So if you're coming on, like I said, just hang on. We're just waiting for Dr. Rodgers to come on.
Yeah, we have a really interesting topic tonight. I'm really excited about this because we were, this is a big, very contemporary issue, but also an issue that has at points over the last 20, 30 years really ebbed and flowed, which is this idea of, should IVF coverage be standard of care, or meaning should everybody have access to IVF? And obviously you and I want more access for everybody, because that's what we want. We want everybody to be able to have access to this incredible technology. But the politicians, they have other numbers that they have to juggle, I guess. And I think one of the really interesting things about talking with Dr. Rodgers tonight is going to be comparing our experiences. She's in a mandated state. We're not. I think this is going to be really, really interesting. I'm super excited to get to talk to her about this. Yeah, it looks like Dr. Rodgers is going to come on here in just a moment. Dr. Rodgers, I'm going to add you to the stage here.
There we go. Sorry, I got kicked off for some reason.
Hi, Dr. Rodgers. Great to see you here tonight.
Hey, great to see you too. Thanks for having me.
Thank you for being
excited. Yeah.
Mark and I go way back.
Way back, yes. I was telling him that we were doing our boards together.
I know. I was trying to think what year that was. I think it was
like it was a long time ago.
Like our older ones were babies, and now they're like 18.
Exactly. Yeah. It was. I told him. I think I probably drove you nuts when we were. It's weird. Why kick them off? Did. Hey Ari, I don't know if you see anything going on there, or why it's kicking her off. There we go. She's back again.
I did the same thing you did.
Yeah, I think I took myself off. But I was saying, I think I might have drove you nuts a little bit, because I told him, I said, I don't know if I was the best study partner ever, but you definitely helped me along, that's for sure. I told him
we got through it together, right?
Yeah, we did. We going to was it Dallas, right? We had to go do our boards, both boards. So
horrible.
Well, one of the things we with this show, it's a place for people to come on live and ask questions and stuff. And one of the things that we've got from a few of our patients and is this idea of California, which is our neighbor now, is going to be going to a mandated state. And
interesting.
And so, a lot of people are nervous about things. And so we just thought it'd be a great show to talk to you a little bit about, being in a mandated state. If you're in Chicago, you definitely got to see Dr. Rodgers. She's the best. I literally send their patients anytime I know someone's moving there. I'm like, you got to see her. And every single one of them say it's a great experience. And so we wanted to know, what's different for you? Because obviously in our state where it's not a mandated state, we have a lot of cash patients. And it adjusts things a little bit, when you have cash patients. Mm-hmm. And so we got some people who are going to be coming on with questions in here. And is there anything you would want to start with regards to, like, in your view, what do you think is different? Because you've been in both, right? Because you used to be in fellowship.
Correct. So I did fellowship in Texas, and then, which was not a mandated state. And then I went to, and I did residency in Cleveland and, did some fertility there. Was not a mandated state. Now I'm in Illinois, and I've been in Illinois since we graduated fellowship in 2011. And what I would say is that I would say about 85% of my patients have coverage for fertility, some sort of coverage. It might not be everything. It might be, some of them it's just inseminations or a certain dollar amount. It doesn't cover always everything they need, but about 85% of my patients have coverage. And I do think it levels the playing field a little bit, because there's a lot of people out there who maybe, have jobs that are good but not super high earning, people in sort of maybe traditionally like blue collar jobs, right? Like factory workers or, other jobs that, may be lower wage and otherwise wouldn't have been able to afford fertility care to build their family. And that I do remember this, like, and it's certainly I still have some 15% of my patients don't have insurance coverage, and sometimes they can't do treatment because they just can't afford what we really need to do. And it is heartbreaking. I know you guys know probably just, even more intimately, like it is heartbreaking to not be able to help someone because of the cost factor. And I do think that that's very helpful. On the physician side, it allows lots of patients to access care, which I think is a good thing. Also I think like on the business side of things, not that this is always a business side, but like as physicians, we actually get reimbursed less per case when insurance is paying for it. So, we work harder and make less compared to our colleagues who are in a non-mandated state. So it would be interesting to see, for the people in California, if they're excited or angry. I would assume everyone's excited about it, because the more patients have care, the better for everybody. I mean, the better for the patients, right? But it is interesting. I definitely think their benefits outweigh the risks.
Yeah.
Yeah.
It's such an interesting point that you make. And we'll maybe I want to ask you a little bit about that, Dr. Rodgers. I mean, one of the common concerns that one hears about, mandated states and things of that kind is that, the caliber of care is affected because you have to see so many patients. And I always tell people that's not the case. I don't feel like that's the case, but I've never worked in, Massachusetts or Illinois or
one of these states. It's a good question. So, here's a question. Do you guys do your own follicle scans?
We do.
Right. So that is one area that I don't do. I don't do my own follicle scans. And I know that my colleagues who are in states, right, I have a sonographer who does that, right? And I see the report, I'm managing the care. Do I think that it's not necessarily that the care is bad, right? Or that the care is less good or the lab is less good, because, we also get reimbursed based a little bit on how good your rates are. I think everyone is a bit like that, maybe not in self-pay state, but I think insurance companies, the better you do from a success perspective, the better they're reimbursing. So, we want to have really good rates for lots and lots of reasons, but that's certainly one of them. I would say that, I don't get that one-on-one time maybe during follicle scans. Right? Like maybe my colleagues who who do their own scans every day. So that's like one thing that I've noticed from talking to colleagues, that they're not like, oh, look, there's a 19, you're almost ready to trigger, right? Like, and yes, I take care of, a lot of patients, but, when I do consultations, I am 100%, I know all my patients, but I also build into the way I personally practice. I can't speak for everybody in Illinois, but personally, I call every patient when I trigger them for IVF cycles. I call every patient after retrieval, whether I'm doing it or one of my partners does it, to talk about numbers. I call every patient with their PGT reports. I call every patient with their pregnancy tests. So like, I'm able to connect with patients and feel that like closeness connection, like I'm there with them. But that is one thing I maybe miss, is like being able to, not that I love doing scans all the time. Like, I'm okay not doing a million scans.
There's two sides to that coin.
Yes. Right. But just spending the time with the patients is nice sometimes, to sort of be there for those little moments.
Yeah. Although we're not in a mandated state, I mean, about my practice, we're a little more affordable. So we run like a mandated state. We do a lot of volume. to be able to make up for the cost because we don't get paid as much. And it's interesting when you were talking, you're right. I get to do the ultrasounds and the patients love it. They do. But I don't have the time to do those other things. So you're doing things that I couldn't do because I don't have the time to call everyone because I am doing the scans. And so it's always a give and go is what it sounds like from that standpoint. We're actually looking at, I'm sure you're familiar with cycle clarity, a new way to do ultrasounds where it just does a 3D, takes 15 seconds, and then we're done with the scans. And at that point, there would be literally zero difference between someone doing the ultrasound. No care would change.
Yeah.
And I was even wondering, like, well, what do I do with that time then? At least I can still talk to the patient. So it's good for you to hear that because we struggled with that sometimes. We're like, if we stop doing the ultrasounds, like, when will we have time for the patients? And it sounds like what you're saying is we'll have the extra time to do it in the other places.
I think I make a point, I know that, Mark, you've been through this yourself personally. I've been through this myself personally. So I get how an emotional, physical, financial, and I was self-pay when I went through this, right? Like it is all encompassing. And so I think that it's personal, and I like to treat patients the way I would want to be treated.
Yeah. Well, we already got some people here, and I know one of them I'm really interested in you talking to. It's going to come up second because she does live in California, and I know she has a lot of concerns, and so I'm really interested in the answers you have for her. We tried our best last week to talk about, but we'll bring on one of these patients, and we're going to bring up Cassidy here. Hey, Cassidy.
Hey, how's it going?
Good. Well, we have, like I said, it's quite a treat to have Dr. Rodgers on here. Just so you know,
Thanks.
People like to joke around, tell me I'm famous. She is very famous.
Oh,
okay,
stop.
Awesome.
So tell me what questions you have for Dr. Rodgers, or any questions that you have.
I was just over here typing up a list of questions, so I don't know how much time I have, or how much time you have. Well, let me a little bit of background because some of these are a little bit specific, but my wife and I are both planning to do an egg retrieval at the same time or the same time frame. So that's where this first question comes from. And our initial question is how many vials of sperm are needed? Can you use just one vial of sperm if you get a different type, or do you have to have individual vials, and which type is best for that scenario?
Yeah, Dr. Rodgers, we're going to let you answer some of these questions because you're our guest.
Oh, thank you. So, I think that it would be pretty unlikely that you and your partner would have an egg retrieval on the same day. So, yeah. And it's probably better to fertilize those eggs right away as opposed to freezing the eggs, thawing the eggs, and fertilizing them all at one time, which is possible. But it would probably be best to get both of you guys vials. I personally recommend having 2 vials. I don't know what your lab says, Mark, but typically what we will do is get at least 2 vials of sperm. So let's just say, are you guys using the same donor?
Yes.
So I would probably consider 3 vials of sperm then. And I would get the ART or IVF sperm. It's a little bit less expensive. And the reason is because if something happens and the vial explodes, if it doesn't thaw right, something happens, you have a backup.
Right.
And it's very, 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 very rare to need it. But when you need it, you need it. And you're not in a scenario where you can just say, please just ejaculate again, right? So you need to have that sperm as a backup for yourselves.
Okay.
That's exactly what we recommend too.
Great. Okay. So along the line of sperm, so we've obviously been doing some shopping around. We've looked at a lot of different sperm banks, and that can be kind of overwhelming. I know you guys are not in the business of sperm banks, but obviously
we are.
Yeah. So we recently heard from a reputable fertility person we've been working with, that one of the clinics that we had looked at for sperm, they were like, I've had really bad experience with them. They just I never get any good sperm from them. So that was kind of surprising for us. Now we're like, all right, well, we trust this person. We're going to start looking at other places. But that led me to wonder, like, how can a consumer ensure that they're purchasing high quality sperm when these sperm banks, first of all, are kind of few and far between for the like more reputable seeming ones. But then like we're not looking at the sperm under a microscope, and it's not like we get a sample of it ahead of time. So what can we do?
Yeah, that's actually a super great question. I will reassure you that the sperm banks are all regulated by the FDA, just like if like any other tissue from one person going into the other. So when we're using egg donors, gestational carriers, sperm banks, whether, you know, it's all regulated. So it should be safe from a infectious disease perspective. You should know genetics, right? I don't know the specifics about the exact bank or why somebody didn't like them or whatever. But you know, sometimes they have guarantees. When you buy a vial of sperm, it'll say like there needs to be at least 5 million moving or something, right? When it's thawed, or you get your money back. And obviously in the moment when it's like IVF and you need it right then, you need to make sure you have good sperm. I usually would recommend that you pick a donor who's had successful pregnancies previously. I'd recommend that for eggs and sperm. And because then you know their sperm made a baby, right?
Yeah.
But I agree. And this is where I would talk to your fertility provider and say, what banks do you work with? And you're right. There's a lot. Like we have a bank that's a local bank that, you know, was on the news for somebody misreading a 3 for an 8, and someone got the wrong vial and ended up with a baby that didn't look exactly the way they were hoping to. And we don't use that bank. It's local.
Yeah.
Like literally you could run across the street and pick up a vial if you needed to, but I wouldn't use that bank. It was one mistake out of probably, you know, whatever, thousands, but like still. So, and listen, people are human, mistakes happen, but you want, you know, this is where I would talk to your fertility provider.
Yeah. And so one of the things, right, is that there's clinics all around the country. So do you guys see any increased risk when there is longer travel required for the sperm from one place to another?
Because they last in those containers for like 5 days, and they like ship them overnight. And even if there was some sort of weather event or something, like usually, you know, it's fine. So like if you're in, I don't know where you live, but let's say you're in California, you could get from Fairfax, which is on the East Coast, or California Cryo, or, you know, where, you know, Seattle or whatever you were choosing, and it would be equivalent.
Okay.
Yeah, there are these tanks that are basically, think of it like there's liquid nitrogen, but instead of liquid nitrogen in it, it's a vapor. And as you just mentioned, it lasts for 7 days. A lot of people even will do home inseminations, have it delivered to their house. They know it's going to be good for about a week. And so they know their ovulation can happen in the next few days. They thaw the sperm and do home insemination. So definitely lasts really well. I did have one question for Dr. Rodgers. So I have seen different quality of sperm done from different companies. And you're right. Like no one's giving like 10% only moving sperm, but I find there's certain companies that just seems to hit the jackpot every time. Great sperm. And then other ones, I feel like we're constantly asking for that guarantee again. Have you seen that? Or is that just maybe of our experience with a couple of different companies?
I haven't noticed, although I will be honest, I'm not necessarily like looking for the like, you know, like comparing. I'm not like, you know, saying, oh, where is the sperm from? Oh, where's the sperm from? Yeah. What I will say is that the rare scenarios where donor sperm is thawed and it's bad, I cannot even tell you that I have a lot of patients who use donor sperm for a variety of lots of different reasons, but like I can't even tell you the last time that we had to like say we need our money back for this vial, because it's so rare that happens, right? And you know, so I think overall the banks in the United States, I would talk to your fertility provider, but like the main banks are fine, right? And if you get a vial and, you know, you do IVF and you get horrible fertilization or something, it's hard to know whether it's unlikely to be the sperm. Maybe it's the egg, but like you can always switch donors if you needed to.
Sure. Okay. Cool. Well, so my next questions are related to CMV status. So I
talked about this a lot today already.
Because this has been a tricky one for my wife and I, because I'm CMV negative and she's CMV positive, and we're planning to do reciprocal IVF. And I say it's been challenging because we've done all of the Googling we can, and there's no direct answer about this. So I'm going to ask you guys, is it possible for someone who is CMV negative to get CMV from a CMV positive embryo transfer?
Okay, so I was literally reviewing this with a patient today who's in the almost exact scenario where, and she's also like not super comfortable using the main banks because they have so many offspring. She wants to use one of the banks that like you pay more and then they have limited offspring. So I was just having this conversation. So there was recently a settlement, like a lawsuit settlement out of Connecticut, I believe, for $36.7 million for a scenario where somebody used donor sperm and had twins and ended up having congenital CMV for the babies. And listen, you can get CMV from walking through the grocery store, you can get CMV from sexual activity, but they were able to convince the judge and jury that they got CMV from this donor sperm sample, and that is like a career ending amount of money, right? For a physician, right? So the question is, was that really a risk? And I think that the data, the science behind is good, but not amazing, right? Like CMV can cause fetal demise. It can cause congenital CMV and like bad birth defects. So like deafness, cardiac stuff, not badness, right? If you are CMV negative, could you get CMV from sperm or from sperm that made an embryo that embryo went into your body? I think it's possible, but very, very, very unlikely. I will tell you that we were allowing patients to move forward with this scenario with a waiver, saying that they understand the risks. The risks are low, but there's risks there. Since this lawsuit has come out, we have decided to not even take the risk, because it's just not fair to if you can get it from sperm, you should choose a donor that's negative. If you have the choice, right? If you were, and I've had patients say, but like, you don't check heterosexual couples, right? Like this seems like, yeah, but I would check a heterosexual couple that was using donor eggs or sperm, right? So I do think that like you are in a privileged place of being able to choose a donor and a donor that's safest for you.
Well, yes and no, right? Because we can choose a donor, for example, who is CMV negative, that would match my status. But my wife is CMV positive, right? So
she would be fine with CMV negative sperm though.
But if I was carrying the embryo.
Oh,
so
well,
her concern is that her wife, because her wife's positive.
Well,
right.
So we assume that you and your wife are sexually intimate.
Right.
Yep.
And so you are exempt from that because you are already sharing germs with each other.
Okay.
So sexually intimate couples have a different status, because we assume that they're already sharing germs.
And CMV is a very ubiquitous virus. I mean, people pick it up, as Dr. Rodgers said, all the time. So in this situation, I wouldn't be as worried either, because you guys, kiss and stuff, you're gonna get it from each other eventually or something like that. So it's not as concerning. So
okay.
we do have one more. We have another person. So I was going to see if you had another question for us, and then we were going to move on to another person. But we really appreciate all the questions so far.
Yeah. So if it's cool, I do have another question. So this one is just related to PCOS. Does, in your experience, and I know that PCOS is huge, it's got a lot of variables and it really depends person to person, but is there an increased risk with PCOS as far as the ability to carry a successful pregnancy? If you have an embryo and a healthy uterus or a ready uterus, is there an increased risk for the ability to carry?
So this is a great question. So we do see for people with PCOS a slightly increased risk of miscarriage. but we don't 100% understand the why, right? And is it because there's some hormone imbalance from like they're not producing enough progesterone? Is it because, you know, they may have insulin resistance? Like we don't exactly understand the why part of that, right? So the question really is, if you did reciprocal IVF and you have PCOS and you take an embryo and you're just carrying it, is that an increased risk? I don't think we necessarily see that there's a huge increased risk with that, right? Certainly, we should make sure you don't have diabetes. We should make sure your thyroid's enough. We should make sure you got enough progesterone on board. But like in general, the person with PCOS, assuming it's you, or should be able to carry a pregnancy. Are you at higher risk for things like gestational diabetes? Yes. That's okay. You know what? You screen for it. You treat it. You take care of yourself. It's okay.
Right. Okay.
You know?
Awesome. Well,
Exactly.
thank you guys so much. And yeah, if you guys want to move on to the next person, that's awesome. And I'll sit here and think. If I have more time later for questions, I'd be happy to join again.
Thanks so much, Cassidy. We appreciate it.
And best wishes on your journey.
Yeah. You know, it's funny. When I was thinking the other day, I won't keep on with Dr. Rodgers, not Allison. But do you remember when you were going through your fertility part? Do you remember calling me and asking me about stress? I don't know if you remember that.
I don't.
So it's funny because I was talking to a patient about this. And I was saying how like when I went through fertility, right? My wife and I were trying things like IUI, and I have like 1.2 million sperm, right? No chance of an IUI working. But there's something about when you're going through it, logic doesn't matter anymore.
It's hard to be objective.
Yeah. And so even though I think one of my podcasts I talked about when you called me and you're like, I know that stress is not making this not work, but could it be stress? And it's so interesting how like, you know, even when you know everything, I mean, you know fertility, I knew fertility, and yet still we started questioning some of those things. And so
it is really different when you're going through it yourself. Right.
Tremendously.
It is, you know, and I will tell you, I was like totally into the like, surrounded with like fertility things. And I literally made my husband drive me to the Ripley's, believe it or not, in downtown San Antonio so that I could go touch the fertility statues. And wouldn't you know that my very next transfer, I had a successful baby. So, I mean, it must have been the fertility statues, right? Like my husband's right. So, but my husband's like, you are a scientist, you are a physician. Like, why do you believe in this stuff? And I was like, because like science doesn't explain everything, right? Yeah.
Yeah. That's why I thought of that. Because I was telling her, because she said, is it goofy that I think this? I said, no, it's not. When you have infertility, you think things. So this next person's coming on. She actually was on with us last week when we were talking about this. And again, we've never been in a mandated state. And she had some really good questions. Some of the questions she was asking were things like, you know, are they going to make me jump through hoops, you know, like when there's mandated? Are they going to have more restrictions and things like that? And that's the stuff we were talking about, but we don't know firsthand. So I'm really looking forward to talking to Joanna because she has some great questions. She's in California, so she's going to be one of those people who are going to be able to benefit from it. And I know, Joanne, we're going to be talking here soon too anyway, so I'll be seeing you in the next couple of days talking. But Joanne, this is the perfect person to talk to. When you spoke to us last week, you spoke to two people trying their best to talk about it. She knows more about mandate than any of us.
I do know a lot about different insurance companies.
What question you have for Joanne?
She left. She's gone.
Oh, well, okay. We'll get her back.
While we're working on getting her back, I will go through a couple things. So, do you have to jump through hoops? So, I'm sure just like you, there is a certain set of blood tests and ultrasounds that you do before you start treatment, right? You need a semen analysis, infectious disease screening. You want egg count numbers, saline ultrasound, or some sort of imaging of the uterus. This is something that is like standard of care, right? And yes, insurance companies want to see all of that before they approve treatment. So, there she is.
There we go. Okay. Hey,
hi.
So nice to see you. I've been listening attentively and excited for the opportunity to ask my question. Sorry, it's kind of dark. I'm in my car because I'm waiting for my son to do a swim lesson. Um, I mean, I feel like I'm kind of I'm a little bit of a worrywart, but I'm also like I'm in a situation where I'm a self-pay patient, and I have had to do just a lot of financial rearrangement of my life to be able to afford IVF. And luckily I found New Directions. I found Dr. A in Arizona, but I'm traveling all the way from California. And so to me, this like new law that could, potentially benefit me is it feels like it's almost like a godsend, but I'm so worried that like I'm just getting my hopes up. I have some questions. I guess like I have my questions, and I actually have some questions from a colleague who is younger and wants to look into egg freezing. So, I think for me, like, I'm a woman with high FSH. I think 5 years ago or maybe 10 years ago, I would have been disqualified from doing IVF because my FSH is like 16. Um, and then I have DOR. So I know Dr. A and Dr. Salem were talking about like not everyone is going to qualify, right?
Yeah, so I can talk a little bit about that. So it depends on the insurance company that you're with. So, like in Illinois, the only one who's really particular like that is United Healthcare. So, my patients with United, if their AMH is very low, and I don't know like they are always changing it, but like it's really low. It's like less than 0.3 or something. If your AMH is really low, if your age is a certain amount, if your FSH is really high, they will not cover IVF. What they will cover though is donor egg treatment. And so they'll say, you need to do donor egg treatment. We're not going to pay for you to go through IVF. Now, I don't think the numbers you're talking about probably would disqualify you, right? However, they, when you have someone else paying the bills, you sort of have to jump through their hoops. So some of the hoops that we have to jump through, I had talked about this when you had left, so I won't go into too much detail, but we need to make sure we do a thorough evaluation before we start treatment. Some of the things like if we do ICSI, sort of routinely, and I know that's a whole controversial issue, but like if we're doing ICSI, some insurance companies, again, maybe not the Blue Cross Blue Shields in Illinois, but like maybe the Aetnas or the Uniteds, they will say we're only going to pay for ICSI if the sperm is really bad, right? If it's a morphology or certain count, they're not going to pay for ICSI otherwise. We see sometimes like at some of the Aetna policies, if you don't meet certain criteria, that you can go right to IVF. If you got blocked tubes, the sperm's really bad, diminished ovarian reserve. But for the average patient who comes in, a lot of patients have to do 3 IUIs before moving to IVF. And that sounds reasonable, but it is really, it can be frustrating when you really need IVF for other reasons, maybe. But I would say that in general, insurance companies that are covering fertility care in general will stay out of our way most of the time. I will say there's a couple of policies, like again, United, I can't increase the dose of meds. So if I look at sort of my FSH plus my HMG or whatever, like if you look at the drugs that we're using, I can't go above a certain amount. So they have a limit of 450, which is a high number, but sometimes I feel like standard of care is probably going to go to 600. And I don't know what you guys do, but like they will not cover it if you go above that. So again, United will not pay for the entire cycle if I try to order human growth hormone. So there's a couple things where I have to be like, okay,
and just to clarify that point, that's such an important point. I want to kind of highlight that they won't just not pay for the HGH.
Drug.
They'll not pay for the whole cycle.
And I mean, I have done things like not maybe just like send it to the pharmacy, but not put it in my orders.
Yeah.
Not on purpose, of course, but like they are like absolutely not, will not cover the whole cycle. And you're like, okay, just kidding.
Yeah.
I actually put it in my note, and all I said is patient may use growth hormone. We didn't even order it, and they wouldn't let her go through until I amended my note.
Yes.
And said that we will not use growth hormone.
That's thing, right? Human growth hormone has like large meta studies, right, that show increased live birth rate. Doesn't help everyone and it's expensive, but like there's really not a reason they shouldn't be allowing it, even if they didn't pay for it. So, I mean, it's kind of some stuff like that. I will also say that, there's insurance companies like Progeny, which is not really about the mandate. So it's just like employer based coverage that's everywhere. I'm sure a lot of employers in California have it, where, they really want you to have the best outcomes and the lowest risk. And this is something they're sort of, when they're selling their products to employers, they're like, we have the best doctors. Everyone has to be board certified. Everyone is an REI. Some clinics are trying to sneak OBGYNs in, right? Like, but one of the things is they require a single embryo transfer always, right? And you can submit like a petition and stuff like that, but like they are really serious about it. And, I think that those are some things that in the long run probably are improving patient care, because I think, it's best to have a single embryo transfer. However, I think that there are some of us who really follow the rules, and there are some times within the ASRM guidelines that it would be okay to transfer maybe more than one, but it becomes really difficult when you have these like kind of rigid rules. So, for example, like Progeny does not really allow you to do without like jumping through tons and tons of hoops, like gonadotropin IUI cycles. And for most patients, that's great because gonadotropin IUI cycles has a very high chance of twins, triplets, etc. Like I had a patient who had hypothalamic amenorrhea, like would not ovulate on oral medicine, did not want to do IVF, and also did not need to do IVF. And all I needed to do was give her a little Menopur and she started ovulating. But I had to like the amount of hoops I had to jump through. And luckily she got pregnant. She got pregnant on the first time twice. But like it was like kind of a lot on the doctor's end too, right? Having all these like prior auths and stuff like that. So I think part of it is also just learning how to help patients, how to help the patients, how to help them get through treatment. And, the providers in California are going to be new to it or newer to it, right? But like, it didn't take me very long to know like which insurance company you have. It's not like it's super burdensome to know which insurance company you have, what I need to do to help you get there. And the staff at your clinic, which sounds like it's, Dr. Amols, but if you're in a mandated state, they should be able to help you navigate that. And obviously in California, it'll be new to them, but like in general, it's sort of our everyday stuff we do.
Can I ask a follow-up? I have a couple more. Just let me know if I'm out of time here and I will like pare it down. But just kind of like out of curiosity. So like for me, I haven't had a successful normal fertilization with any of my eggs. Is that something that like for insurance purposes could be treated as like an existing condition and they can say like we're not going to give you the opportunity to do IVF because clearly you haven't
I don't think so. No.
The ACA would have stopped that. There's actually illegal to have existing conditions. So
Well, hopefully the ACA stays around. We'll see.
Okay. I'm really curious about this too. When you were earlier having a conversation all together about like kind of keeping care feeling personalized, Dr. A and Dr. Salem were talking about doing your own follicle scans. And like, I'm just curious about like, is that like, what do you like with a larger practice with kind of a higher surge of patients incoming, like what do you guys do as doctors to make plans and the care still feel personalized with higher volume?
So that's a great question. I think that, so like the way I run my practice, and I'm the busiest doctor in one of the busiest practices in Illinois. And what I would say is that, my patients are assigned to a specific nurse. It's not a random person calling them. Like you always have Stephanie calling you with your test results, and you get to know that nurse very well. Stephanie and I work together to take care of you. I review the results. Stephanie will call you and give you those instructions. You can ask her questions. She's your person. And then I personally will call you multiple times throughout your cycle to check on you, see how things are going, right? I do trigger after retrieval, after end of culture with your PGT results, and then you're coming back and talking to me, and we're sitting down and talking through everything. So I think that I don't think you should pick a doctor based on whether they're doing their own follicle scans. I mean, it's amazing that Dr. Salem and Dr. Amols get to do that. But I don't know if like that is the defining factor, right? It is also very individual. I think that different people's personalities fit better with different doctors, right? And it's really important that you sort of use your gut, right? It's when you're picking a fertility clinic, it has to do with your ability to communicate with the doctor and the nursing team. And then also when you're doing IVF, it has to do with the lab. You know, the lab is a big factor in your success.
I think that for like patients, it's really hard to pick accurately. Like, I think one reason I went with New Directions is because I had the Taco About Fertility podcast. And so like being a teacher, I could kind of see Dr. A's like style of teaching. And I was like, oh, I can have rapport with this person. Like, I understand the way he's explaining it. But I think that like besides the CDC data, like for me, a layman, like I don't even know how to look for things like lab quality, you know, and like that's not the type of question you can ask until you get to a consultation. With some
But I do
clinics are like
think
this, right?
the SART data is a great place to start. You know, I mean, that is a good place to start. I will say this about SART data. First of all, you got to take it with a little grain of salt, right? Because the clinics that are willing to take on the hardest cases, like, you know,
Right.
if I
They're not
take you
gonna have
on, right? If I take you on as a patient and your chance of success is low and you do 4 cycles and you end up with 1 pregnancy, you know, I get a 0 3 times and then 100% once, right? Like if you're doing that math, it's not great, right? And there are certainly clinics who pick and choose the patients they're willing to take care of so that their rates are higher. And other clinics that are like experts in the field that have amazing rates that take on the hardest cases, even with the poor prognosis. So you do have to take it with a grain of salt.
I find the CDC, I actually think it's better than SART. I think, unfortunately, SART has done a bad job recently of presenting the data. And I
Yes,
think
I actually
read
agree
it,
with you.
it's harder to kind of realize, you know, because like you said, it's the denominator now is affecting the rates and it makes it look a clinic look really bad when they're not. And so that's where I think the CDC right now is actually easier to follow. The one thing I wanted to say, Joanne, that Dr. Rodgers talked about earlier, which I thought was really interesting, was she calls all her patients with some of the results. And I know I don't have the ability to do that. So although, as she was mentioning, I may be able to do all the ultrasounds. It does. It takes a long time for me to do all the ultrasounds when I do follicle tracking. I don't always have the time to do some of the other stuff, and I have to rely on my nurses for that. So it sounds like there's just a little give and go. But the nice thing she mentioned is she still builds that rapport. And it may not be just directly right then, but at least, you know, still talking to them and going over things. So I think that's the good thing you can look forward to. She did ask a question last week, which I thought was a great question, which was, and I didn't know the answer to this, Allison, was when you have to have, if more clinics are now going to be doing more IVF, because we would expect that the numbers will go up. Is it harder to get in the clinics? Like, you have longer wait time? Because I know, like, at our clinic, we have a little bit of a wait time, but there are some clinics you can literally get in tomorrow in the Valley.
I think that it really depends on the clinic. So, like, I think it depends on clinic. Like, we just hired 4 new doctors, and their schedules are not as like booked out as like other people. So, like, you could get in tomorrow, right?
Yeah.
I think that if you look at clinics within Chicago, which is sort of this big hub, lots of fertility clinics, also lots of people who need fertility care. You take a clinic that is an academic clinic, let's just say, and it is you're right, 2-month wait time to just get in, right?
Yeah.
Whereas my clinic, I'm the busiest doctor there. You could probably get to a new patient appointment with me within about 2 weeks. So we try to make sure there's new patient slots available. So, and then also making sure we have to, you know, be able to make sure we take good care of our existing patients too, right? I will tell you that, like, personally, I got so busy that I actually had to shut my practice from new patients for like 3 to 4 months over the summer. And people were really upset about it. But like I literally was having, it was this 8-week wait time just for my established patients to see me. And that's not good patient care, right? And
Yeah.
you don't want to do a cycle and then not be able to see me for 8 weeks. And I'm like, only have so many hours in my day. So I actually shut my clinic down, like my new patients down. I discharged like 150 new pregnant patients, and then I opened my clinic back up, and now people can get in to see me sooner. And I'm just going to be keeping a little closer eye on that because it got a little out of control. But like, I think it depends very clinic to clinic how fast it is to get in.
I mean, that's amazing that that you did that and that you were able to do that. I think that a lot of people would have like some hesitation or trepidation to do that, and that really speaks highly to the fact that you're kind of
Thanks.
No, really. I mean, that's really impressive. I do wonder though what others would do, when they were confronted with that situation.
Yeah.
8, 9, 10-week lag between, being able, having gone through a failed cycle and not being able to see your doctor. Do you see, or do you think you would see patients just saying, okay, well, I'll just go through another cycle without seeing my doctor, or just keep it moving forward?
Maybe. I don't think that that's great care. Like, I think that you probably should do a cycle and then do a debrief and figure out like what went right, what went wrong, what do we do next? And did I have some patients who like decided to switch over to my partners because they didn't want to wait for me? I did. And at that point I was like, yeah, this is not, but I agree. I think I'm here to take good care of patients, right? And I'm not worried about like dollars on the back. Like, we make a good living. Like, I'm not worried about the dollars. I'm not worried about like, the statistics of like how many people or whatever. I want to take good care of the people I'm taking care of. And there were some like people who had to wait. I closed my new patients, so they had to wait like 3 months to see me, and they were not happy about it. And a lot of people went to see other people in my practice or other people outside my practice, but it wasn't fair to the people who were in the middle of treatment. So, and that was the first time in my career I've had to do that. In fact, the first time in my practice anyone's had to do that. But luckily I had a lot of partners who had openings, and like I said, we have a bunch of new doctors, and they were happy to take some of that overflow, and we were able to get the patients in as a practice. But like, we're all just one person. We got only so many. We all got the same number of hours in the day, right?
Yeah, well, I dealt with that too. When I was by myself, we were booked out so far that I actually had to shut all new patients down because it was just getting so ridiculous how far it was going out. And you're right, people get upset, and it's not us that we try to do it. So, Jordan, what other questions you have for us? We got another person we're gonna talk to in a minute, but just see if you have any other questions.
It's sorry, I'm just like absorbed into listening, because I think for me, like, talking about the care feeling personalized, like so much of that is that follow-up, because you're waiting and and then
Worse.
really vulnerable, and it feels like the only person who can give you clarity is the doctor. So I'm glad to hear that that's something that is on your mind too. Like, you're trying to not have patients wait and wait and wait, and you're trying to give them the before the next cycle.
Well, and what I would tell everybody out there is that like, you also need to advocate for yourself. So I have systems in place that like, if I'm doing your retrieve, your transfer, you're setting up your pregnancy test and your follow-up, right? Like, and then I have to like go back. Like, if you're doing stim start, you're already setting up your next appointment with me so that we can review things. Where things don't go well is like, if God forbid there's a cycle with failed fertilization, failed blastulization, and I'm not waiting for PGT anymore because there's nothing to PGT and I need to get them in sooner. That's sometimes where things are tricky. But like, you should always, when you're leaving your clinic, you should probably have an idea of when you're seeing your doctor next, and like set up the appointment. If like, yeah, I'm like starting my stimulation, I'm going to stim for 2 weeks, and the embryos are going to grow for a week, and then it's going to take about 2 weeks to get my results back, maybe 5 to 6 weeks. Make sure you get an appointment on the books. Be proactive.
Yeah. Joanne, just to give you an idea what she's talking about, I mean, like at our clinic, what patients sometimes who don't want to follow up, they'll say like after it failed or so, and they're like, we want to follow up, we're done. I require them to have a follow up to the point that we won't even charge them. It's so important to have that closure. It's so important to have those things. And we do think about it. Trust me, if I could call every single patient, I would. I wish I could. It's just unfortunate, as Dr. Rodgers says there's only so many hours in a day, and that's why we have to use our staff. And that's why we, I think that's where, as Dr. Rodgers is saying, you look at a clinic and go, hey, are they getting back to me, right? Do I feel good about the rest of the path? The staff is really the most important. I mean, we get all the credit, but in reality, I mean, it's our staff that really is what runs the clinic. We do the best we can, but that's the support staff that really, is what you have to look at. So, Joanne, thanks so much for coming on. I know we're going to talk here soon. And I was thinking about you when I knew Dr. Rodgers was coming on. I'm like, this is going to be the perfect person to ask. You should ask questions. So
good luck, Joanne.
Thank you. I appreciate it.
All the baby dust to her.
Now, we're definitely going to make sure we, stop this show on time because, here it's 7, there it's late. And I know you work long days. So
I know I haven't eaten dinner yet, but that's okay. I'm not hungry yet.
Neither have I. So that's what I was saying. So I want to make sure we get done. This next guest that we're having come on, he's got a couple of shows. He's actually someone I know very well. Great guy. You may know him. I don't know if you know Steve Rooks. Do you know him?
I may know his face. The name is not familiar.
Yeah. Well, anyways, what's great about Steve is that he's in Canada. So again, kind of similar mandated area, and they're changing things a little bit in Canada to make more efficient systems. So this guy's just the best at efficiencies, and we have all these conversations. So I love to see what he has to ask us tonight because he always comes up with some great questions.
Is he a fertility doctor? Are you a fertility doctor?
No, I've come to love fertility. So I was the chief operating officer at the Fertility Partners, which bought up a third of the clinics in Canada, coast to coast, and then Illum or Army, Connecticut, in Connecticut. And let's just say I got myself fired because I told my boss one too many times he was wrong. He didn't quite like that. But anyway, so because of guys like Dr. Amols and Dr. Salem, I've decided to try to find a new opportunity in fertility because I see there's so much opportunity. I was at Resolve last night, for example, and there's such a passion, of course, with all the practitioners, and there's just so much opportunity to help because. As an example, as you well know, I did some bottom-up analysis, and we're only treating a third of the people. It's only 25% in Canada. It's maybe a third in the U.S., and the other 2/3 can't afford it or can't access it, et cetera. Whereas, recently I heard that Spain's up to 10+% of their babies being born via ART, while here it's 2.7%. So,
which is interesting because it is a Catholic country and there's a lot of restrictions there.
On privacy and other things. Well, Italy's the worst. Italy's the worst for the. I think Spain's more open, whereas Italy is much more controlled. But I wanted to ask this dumbass Canadian kind of question of, I don't get why there is some faceless person, or maybe they have a face, in all the payers who are establishing all these criteria for treatment when I would think that the docs know what standard of care is and should be the ones that, so I'm curious. I mean, you did say that some of them are actually pretty good, but like United, for example, who is making these restrictions up? Is it actually a chief medical officer who's an REI who can make those decisions, or is this some bureaucrat trying to save money?
This is a great question. So I will just give the example of Aetna Insurance. So in the past, they required 6 IUIs before moving to IVF. And patients were like, it was a lot. And they then met and reduced that to 3 over the last maybe 3 years. Yeah. So I often will have these peer-to-peer conversations with the medical providers, the medical staff of the insurance company. And what happens is that, I say, I think the patient needs this. Mm-hmm. And they will say, let's take a look at this case because it was something that was denied, right? And 95% of the time they're like, sorry, this is I agree that this is good for the patient, but their employer is not going to cover it, and it's not in their plan, and it's not covered. So then that patient is self-pay for that portion, whether it's ICSI or the coverage for genetics. Like Blue Cross covers the biopsy fee for PGT, which is whatever, $3,000, and then they just have to pay for the per embryo fee, which is a lot less, right? So I do think that there are medical boards behind this. I don't think it's always reproductive endocrinologists or people who totally are in the field.
Rarely are guys.
Yeah, it's not
Yeah.
really REIs. So there might be some OBGYNs involved. But I do think those sort of rules and regulations are in place for two reasons, right? The number one thing is to provide care and have some structure to what
Mhm.
people are doing so that their expenses are not like, unreasonable. And so they obviously are there to make money, right? As any business is, but they are there to make money, and they want to provide the service, but not have it be unlimited. And so that is where some of these rules come in. And there are certainly insurance companies that are so much easier to work with that like kind
Yeah.
of are, like the Blue Crosses that are kind of like, you do the right thing for the patient. And then there's other insurance companies that have rules and regulations in place. And you know what? I will say that there are some patients and some providers that like are maybe doing things that are a little on the edge, right?
Yes.
And so I get that these rules and regulations in general are there to protect patients, right? You do
Mhm.
not want a 47-year-old doing 100 cases of IVF or even probably one, right?
Yes.
So I think that some of them are there to try to put some like medical and guardrails up for some physicians, and for those physicians who are like really good practitioners who are following all the guidelines, who are really like taking each case as an individual. It is frustrating, but there are some practitioners out there who are kind of like maybe living on the edge a little bit
Yes.
so I can see both sides of it.
Yeah.
Yeah. I think
You
go
go.
ahead, Doctor.
No, you
No,
go.
I was gonna say very, very quickly. So, Steve, great seeing you last night in New York as well. So I think definitely one thing that's important is that this is just, utilization management by legacy insurance companies. So legacy insurance companies, Aetna, UHC, what they're trying to do, of course, is they're trying to minimize the amount of money that they're spending while still covering this benefit.
Yeah.
Many times, if you look at their, medical rationale for it, much of what they outline is pretty outdated. I mean, I've looked at these things, I've reviewed a lot of these contracts, and they're referencing papers from 15 years ago. Our field is one of the fastest moving fields.
Yeah.
So
that's what I was wondering. Like, do they actually have in their justification when they deny you something? Is there actually some kind of justification that's played out, or they say sorry, and so that you would think you'd have that ability to go back to them?
Yes. So I will say this. That being said, if there's something in the field that comes along that is like pro limiting care, they're all about it. So for example, I've had a couple patients who were recently denied coverage for ICSI, even though we're doing genetic testing, even though we're whatever, because some, there's some recent discussions about like, if we need to be doing as much ICSI as we're doing. And, and so the insurance companies are jumping right on and saying, you're right, maybe we don't need it. And it's the same insurance companies that are limiting other things and are a little bit more restrictive.
Whereas you point out Progeny, like the new fertility benefits managers are much more forward about ensuring an effective outcome for the patient and focusing more on that than on the cost control aspect.
Well, I think they're doing both, right? Because they need to stay in business as well. However, like on the Progeny end, right, they cover PGT, all of it, right? They even cover donor egg for certain employers. And, their goal is to help, have a successful outcome.
Yeah.
And so sometimes patients like might not even need IVF, right? Like they probably would benefit from trying a few cycles of IUI first, but then can't like because they have a limited number of these smart cycles, like are sort of encouraged to do IVF because the chances of success are so much higher. Yeah. So that I think is like my one thing that is a little frustrating, but in general, you're right. Best outcomes for the patients.
Yeah, exactly what you were just saying. That's the same. I was going to bring up the same point about this idea that decisions take time to come down, and to make a change takes a board, and so they always seem to be behind. We were just talking to me earlier that they're still using day 3 labs for everything that make decisions here, versus they won't even let you use an AMH. But I think the other thing is sometimes there's consequences that aren't expected. So Dr. Rodgers talked about with progeny. I mean, I see people who are 25 years old who probably could do an IUI and do 4 cycles of IVF. And unfortunately, that the doctor who they're with is like, well, listen, it doesn't cost you anything. Let's go through another one. And they bank up all these embryos for no reason. So there are some disadvantages. The other disadvantage consequences that come from these things are, for example, there are, as Dr. Rodgers brought up earlier, putting back 2 embryos sometimes. It's not, most of the time we tell everyone one embryo every time. But there are times it is appropriate to put back 2, but if you don't hit this little box that they have, you can't do it. And there is sometimes cost to people on this. So like, I'll give you an example where progeny I thought was a really interesting thing. They want everyone to do 1 embryo transfer, which I agree with. But if you had their smart cycle, you only have 1 transfer. So if you didn't get pregnant, it costs you more money because then you had to pay for the next transfer. Where if you put back 2, you have a better chance. So these things, no one did these things intentionally, but like I said, it creates these things. So like our clinic now, one of the things that we've dealt with is, I thought this was interesting, Dr. Rodgers, is SART, because SART, everyone in their SART has to have, the right criteria, the right testing, everything, all the boards, certifications. They know now, the companies know that they can just say, hey, do they have SART certificates? Then we know we can work with them. Whereas the past used to be able to just send stuff to the CDC. So anyways, what's happened recently is everyone is basing, even if you're, let's say, using cash only patients, if you're doing 2 embryo transfer for cash, let's say you're doing that, you're still being looked at for everything, right? And so now we've been forced to do things that we don't want to do, like you said, because of the fact that we will lose contracts. And so it's interesting, like it's a good thing. And I think not just about money for the standpoint of making money, but if someone does get triplets, right? I mean, that's $1 million medical expense. And so even at 1% risk, if you put back 2 embryos or euploid, that is at least 1 out of every 100 is going to get triplets potentially. Yeah. And that's $1 million. So there is reasons for these things. Yeah, exactly. I'm probably being very generous.
Probably 1 million per kid in a NICU. Yeah.
Exactly.
I heard something interesting that with Maven's recent success against progeny, particularly at Amazon, Maven is coming in with more of a cost control management. So they're now pushing, Maven at least, is you should do, in the right circumstances, a couple of IUIs before IVF to ensure you're doing the most cost-effective path to having a baby, where it makes sense. So they're probably not putting as much onerous hoops as you would have for a regular payer, but they are layering that on. And I think it's very likely that progeny is going to have to make a little bit of a shift in that direction too, to say, hey, at your age, you don't think so?
No, I know they won't. So this is an interesting thing. Progeny actually says, oh, no, do IVF. They want you to. Their model's different. They make money based on stuff. So I don't see that happening with progeny, but I do see that happening with.
They could be with how Maven took that big contract from Amazon from them. They may be forced to reconsider things.
That was, I think, a huge shift. Amazon employs so many people all over the country, and I think that losing that contract, I mean, sort of everyone's talking about it too. And I know, a lot of people are negotiating contracts.
I was pulled into some expert calls around this where he had external investors kind of talking about, well, what do you think Maven's trying to do, and is Prodigy going to respond? And I gave my best opinion, but it all depends. If they lose one more to Maven, they may have to reconsider things. So.
So full disclosure, of course, I'm the medical director of Maven.
Oh shoot, I forgot.
And wait, full disclosure, I do sit on a medical board at Progeny.
Yeah, so both companies I think are really excellent companies, and they're trying to do things in a slightly different way, and I think everybody wins at the end of the day. I really
absolutely do. Yeah, no, I mean, it's all about getting care to the patients.
Yeah,
correct.
And helping employers see. I have patients all the time. If 85% of my patients are getting, have insurance, that like those 15%, I'm like, why are you still with your employer? Right?
Yeah.
Like people are switching jobs And it is something that is attracting the best employees because, listen, if you're not caring about their families and their ability to like have what's going on, the best life on the outside of work.
Actually, it's funny. I talked to a few female startup founders in the Valley, and they're telling me there is a thing in the Valley where you take a Google sabbatical so you can get your eggs frozen, and then you go back to, a startup.
Wow.
Right. I mean, I think it's definitely, one of the highest parts of healthcare utilization among young, healthy women is fertility benefits. And I think at the end of the day, our whole healthcare system, we're trying to get away from paying for procedures and paying for outcomes.
Exactly.
And, that's probably where we should all tack. It's hard to do it though. It's hard because you can't guarantee an outcome, but you can guarantee that you will deliver your best or give your best service. But I think, that's where we're trying to tack, where Maven is trying to tack, where I think kind of the probably the most innovative groups are trying to tack is trying to deliver on outcomes. And this is, again, why the mandate is a very big question, because mandate guarantees coverage of doing something, but it doesn't guarantee an outcome.
Exactly.
I mean, I hope one day we can mandate an outcome too.
This is where, firms like Gaia is stepping in to bridge that gap on the cash pay side by providing insurance on the back end. So in a way, it's trying to get to that outcome, in that model. But, like you said, it'll take a while to get there.
Well, before the end on this, because we are going, and by the way, there are multiple ways to skin a cat, right? So, I mean, literally, I could clap my way to Progeny, Maven, all these places. I mean, I remember a time when no one had insurance, and there was just a very few people had insurance. So no matter what, whether it's perfect or not, it's great that everyone's getting insurance now.
Absolutely.
And you see things like California now. I mean, this is going to keep going across the country. I can't wait till it's completely mandated. But I'm going to bring up this controversial thing because someone asked this question. And I know I'm a very optimistic person. So I look at yes. But I when you said about the ACA, I thought this is a perfect question for Dr. Rodgers. And that is, both candidates going through said that they were going to make IVF mandated across the country. Both of them said they wanted to make it free. Obviously, one won, but they both said they would do it. Do you think?
I don't know if they said free. They just said they were going to require it coverage.
Yeah. Coverage. Yes. Correct.
Yes.
I think one person did say free. I think Trump did, which was obviously crazy because, you can't make it free, but there has to be something in it. But the question is, do you think it's going to happen? I mean, do you feel like that is the turning of the tide now, that when you have two candidates on both sides saying this needs to be something? What do you think?
Gosh. Okay. So this is a really complicated question, and I'm going to try to break it down in the way my brain sort of thinks about it. I do believe that the majority of Americans think that fertility coverage and things like IVF are a great access, scientific, care in terms of building families for people who are infertile. I do think there are, certainly some concerns. We saw this in Alabama. We've seen this where there are some legislatures and judges, right? Because what happened in Alabama was really one judge made one ruling, and it had this huge ripple effect into a lot of other sort of scenarios, right? To the point where people stopped doing fertility treatment in the state for a hot minute until the legislature stepped in. Although that is only up good until I think the end of this year, and then that ruling is also up in the air. So I think that I'm glad that it's talked about. I'm glad that both candidates were talking about it and passionate about it. I do have some concerns because the right to IVF bill came up twice in the legislature and failed twice. And so I would love if President-elect Trump would be able to put pressure to push this through. I think that it's going to be more complicated because it's not just one man making a decision. It's, the legislature and then state by state, and certainly the states that are more conservative, more red, have a lot of other reproductive restrictions. I think it's going to be difficult. I mean, I will tell you that in Southern Illinois is a very sort of red area. And I was on our ballot in Illinois was a what we call an advisory question about whether IVF should be considered unlimited fertility care for companies that cover and pregnancy benefits, and it passed. It passed, meaning 73% of people in Illinois felt that, like, if you're going to provide care, it should be unlimited. And you know, I was on a news station in Southern Illinois about what my thoughts were on this advisory question. It is not a bill; it was an advisory question for the legislature to understand where people were, and they had me saying, yes, the more access to care, the better. We should allow patients and their doctors to make decisions about care. And then literally they had on the same segment, right, a woman from a religious organization that was like, they're killing embryos, they're killing babies, they throw embryos away. This is immoral, right? Like, and, you know, I do think that, and I'm not going to say that discarding embryos is not, you know, discarding something that has the potential to turn into a baby, right?
Yeah.
However, I do think that it is a very much more complicated issue than either candidate probably made it out, right? And I hope and really hope that Trump, you know, is good on his campaign promise and that he is able to work with the legislature. You know, he's got all three, you know, the House, the Senate, him.
No excuses.
He's got the judges, he's got everybody, right? Like, he should, if this is something that's important to him, he should be able to help.
Yeah.
I do have some concerns about some of the very conservative religious right.
Yeah. So it was interesting. Someone just asked, I think it was actually Cassidy was asking this, which was, do we think it will also be for LGBTQ? I think so. I think we are at a point in our country now where I can't imagine a bill ever making it through without that. Because even in the military, I know it's covered there. So I can't see that now. Again, as you said, there's always these far right groups that are, you know, religious right, that will sit there and try to stop these things. But I really believe they're the minor. You know, I know people who are Catholic.
I thought so.
Who do IVF.
Of course, yes.
I still believe that. Again, I'm being optimistic and stuff. But I think, you know, I know at least our organization would 100% be against that. We would be like, no, you can't just make IVF for just heterosexual couples. Like,
Absolutely.
our whole organization would be like, absolutely not. I think fertility doctors would say, we're not even going to support that because that's ridiculous.
Well,
I can't see that happening for that reason.
If you look at a country like South Korea, which is a democracy, they do not allow donor sperm usage for single or same-sex women. The only way you can use donor sperm is if you're married and your male partner doesn't have sperm. And it's somebody you know. It's like a known donor. So it's interesting though, right? I think, you know, we feel like we've got all these rights and they can't be taken away. I don't know, right? Like, it's going to be interesting to see what happens, because I think that there's going to be a pretty big shakeup in government, and we'll sort of have to see. But I think one thing that we can guarantee everybody is that people like all of us are going to still be there doing everything we can for every single patient that's in front of us.
Mm-hmm.
Yeah. And you know what? We got to get you back on here, no matter which way it goes, that we'll have this discussion again, because you're right. I mean, no one knows. I just, the one thing I do know is, I think we hear a lot of things on both sides, but I mean, I just can't imagine the medical field being okay with that. I just can't see that happening. You know, I said where it takes away those rights and us become like South Korea. You know. So.
I hope not, but yes,
obviously
I'm an optimist as well, and I believe that, you know, we're gonna, you know, hopefully continue to move in this right direction and be able to take care of all the patients who are hoping to have families.
Well, Steve, thanks for your question. I'm gonna get you off here, and then we're gonna say goodbye to Dr. Rodgers. And Allison, like I said, I really appreciate coming on. I was really excited about this. You've been a friend for years. We've always, when you came here, you visited my family, and like I said, I always appreciate your time and you know, coming on here. And if you ever want to come again, let us know.
Oh my gosh, I'm always happy to be on. It was such a pleasure. Thank you so much for having me.
So
I
much
thought
fun.
you have fun. You have a good one. And again, thanks for your time.
All right, bye guys.
Bye-bye.
Bye-bye. See ya.